thanks again and welcome to this interesting session. I try to be a bit shorter that Martin also has the possibility to give his opinion on. However, I absolutely agree, CAR-T and bispecifics are so exciting that it was a true pleasure listening to Niels and his update. So I would like, from my perspective, to shortly review data on the frontline treatment. And for me, one of the most important presentations was in the late-breaking session at EHA. This was the update of the so-called Maya trial. And why is that so important? I think this was really practice changing. When we initially saw the data like 2 years ago at the ASH meeting, it was practice moving, I think, and now it's practice changing, as it is the broadest new standard we have in frontline treatment for all patients who are not qualifying for stem cell transplantation. So depending a bit on the country and on the traditions of treating myeloma, all patients older than 65 or 70, or depending also on comorbidities, that primary high-dose melphalan therapy is not considered. However, this is the majority of our myeloma patients, and so I think it's really important to have here such a great new standard. In this trial, daratumumab as the monoclonal anti-CD38 antibody was combined with lenalidomide and dexamethasone, now a well-known all-oral immunomodulatory treatment, which is given until disease progression or unacceptable toxicity. And so patients in the antibody arm received daratumumab in addition to lenalidomide and dexamethasone. And what is very important is this was a very kind of liberal trial. So also patients with significant renal impairment could be included into the trial. And that the investigators, the treating physicians, trusted this regimen to be very well tolerated was reflected that nearly half of the patients in the trial were 75 years or older. What we saw initially is that, and with a new standard, this is very important to communicate, with daratumumab in combination with lenalidomide and dexamethasone, the response rate, meaning patients achieving a tumor reduction of more than 50%, so partial remission or better, is 93%. So we can now say to a patient upfront, in more than 90%, you will achieve at least a partial remission when we are now starting your treatment. And I think this is one of the really great achievements we made in the last years. And when we look on the right side on the progression-free survival, so the time until relapse or death, but this is especially the time the treatment lasts, we see that after nearly a median follow-up of nearly 5 years, the median was still not reached. So we currently estimate that this is around 55 months. So meaning that nowadays a newly diagnosed patient with this triplet combination can stay in the average for 4 to 5 years or even longer on this treatment. And now having the daratumumab also sub-Q available, it's really, I think, a great progress. And this year, Thierry Facon showed that it made a survival difference if you added right up front the daratumumab as the monoclonal anti-CD38 strategy. And the trial now showed a significant benefit in overall survival of our patients when they receive upfront the anti-CD38 strategy. So for me, these are really, really practice-changing data. I saw in the chat one question: are there current studies trying CAR-T therapy in newly diagnosed high-risk patients? Not only in newly diagnosed high-risk patients, there will be a trial randomizing the bortezomib, lenalidomide, dexamethasone, the VRD versus primary CAR T-cell treatment in all patients who are transplant ineligible, and this is planned to start in 2022. So for the transplant eligible patients, we looked on the Cassiopeia study, a huge study, introducing also here the anti-CD38 strategy in primary treatment of myeloma. But now we look on the transplant eligible patients. And for us in Europe, and this is ghosted here, you don't see it so clear, the combination of the 4 drugs, daratumumab, bortezomib, thalidomide, and dexamethasone, was established as an induction treatment before high-dose melphalan and autologous stem cell transplantation with this randomized trial, randomized against DTD alone in induction and consolidation. And now the investigators looked on the second part of the trial, where they randomized after consolidation patients again into daratumumab maintenance versus no maintenance. And this is a bit unusual, as the only approved maintenance treatment currently is lenalidomide. This was not investigated in this trial. However, I think the data were important for you as patients, because first of all, we see doing maintenance, and this is the blue, the purple curve, is better for progression-free survival than doing no maintenance here in yellow, and this was significant. And this was what we always also saw with lenalidomide. So maintenance is clear. However, in this trial, it was surprising that looking who benefited from the daratumumab maintenance, we saw that this was heterogeneous. The poorest outcome here had patients never receiving daratumumab in the trial, so were randomized in the VTD arm and received no maintenance. However, patients who received the daratumumab in front in induction and consolidation and received no maintenance were nearly as good as those receiving daratumumab in front and daratumumab maintenance, or those receiving not daratumumab in front but daratumumab maintenance, meaning that it's very clear that you have to start as broad as you can, that you have to introduce the anti-CD38 strategy as early as you can. If those 3 curves, green, yellow, blue, will separate during a longer follow-up, we don't know currently, and we have to wait. So I would like to make a last short point before handing over. We looked from a broad side on high-risk myeloma, and now I show Martin's slides, who will follow after me, and he can explain that better. But we saw at the EHA 3 presentations focusing on high risk, and I think this is a very important message for you as patients, that we focused on this challenge and really try to improve very clear and looked how we can do. The UK colleagues did an approach also introducing the monoclonal anti-CD38 strategy, and then using a quintuplet with with cyclophosphamide, bortezomib, Revlimid, and Dex. And they showed that in high-risk patients, very high overall response rate could be achieved, and high rates for minimal residual disease negativity. The Forte trial, which is a trial of the Italian study group, comparing carfilzomib, lenalidomide, dexamethasone, here showed as the KRD regimen with high-dose melphalan, and comparing that without high-dose therapy or with carfilzomib cyclodex and high-dose melphalan, and again a randomization in maintenance. This is complicated, but what I wanted to point out, also those colleagues looked especially in high-risk patients, and they had a broad definition for high risk, but they saw that carfilzomib, len, dex, and autologous stem cell transplantation, this is the light blue curve, this was crucial for high-risk patients to have a decent outcome. And we, in our German cooperative group, we presented the data from our concept trial. We use also carfilzomib, lenalidomide, dexamethasone, but we add as a fourth drug the isatuximab, the second monoclonal anti-CD38 antibody, now also approved in relapse, the second one beside daratumumab, and we use this also in induction, consolidation, and maintenance, and use that also for transplant non-eligible patients and include only high-risk patients. And we also were able to show here, we for the first time opened the PFS curve, a plateauing, promising PFS, only high-risk patients, and 100% over response rate in induction. And I think these are early data and they have to mature and have to consolidate. But I think for you as patients, it was a clear sign. We do care about high risk. We try to improve. We want to move forward. And there are clear steps improving the prognosis for high-risk patients. And with that, I would like to thank you for your attention. Would like to stop and hand over to Martin.